Everyone see my screen here?
Yep.
Okay, good. So this is a story of a 17-year-old male who has a history of global developmental delay since infancy and has a history of abnormal movements, including dystonic flexion of the head, jaw, and extremities, as well as generalized coriform movements at baseline. He presented to the emergency department with significantly worsening movements, as well as generalized spasms of 3 days duration. His parents report that he has been on Artane for these movements, and his local neurologist was in the process of slowly tapering it off, but the parents abruptly discontinued this 4 days back. He's currently maintaining at baseline, but is not eating or sleeping well because of the generalized spasms. At the local emergency department, he received multiple doses of Ativan, Benadryl, and Cogentin without persistent improvement, and so he was transferred over. In the past, he's had an extensive workup, including 2 brain MRIs, multiple EEG monitorings, extensive metabolic workup, as well as CSF neurotransmitter studies that have all been unrevealing. He has been seen by medical genetics and has a normal mitochondrial sequencing as well as chromosomal microarray. And finally, the whole exome sequencing revealed a mutation in the GNA1 gene. He's currently on Klonopin and Baclofen. At this time in the ED, he's hypertensive, tachycardic, and febrile. His exam shows significant neck, jaw, and wrist posturing, with initiation of voluntary movements, as well as rapid and repetitive generalized dystonic spasms that are making it difficult for him to sit still. His labs show a mild leukocytosis, an AKI with a serum creatinine of 1.2 and an elevated CK in the 1800s. Now, at this time, given his baseline dystonic condition, we are worried for a storming, and so the patient gets admitted to the ICU, where supportive measures are initiated. These include proper IV hydration, frequent monitoring of labs, and frequent checks to assess for worsening symptoms as well as respiratory compromise. He is on scheduled Ativan and Haldol with rapid cessation of movements, and these were eventually discontinued over a period of 2 to 3 days. His parents at this time did not want to start Artane, and so he was eventually discharged home on topiramate, baclofen, and Klonopin, with a plan to consider tetrabenazine outpatient pending insurance approval. So currently he's doing really well and follows up at the Movement Disorders Clinic here. And these are videos of his post-hospital follow-up. So the first video, as you can see, he is sitting normally with maybe some posturing in the wrists here. And on asking to initiate a movement, he has this rightward head tilt. He has this dystonic flexion in the wrists, and he has these movements very coriform. He's able to touch his nose without any dysmetria, but he has significant posturing in the neck and the wrists. And then on asking to smile again, you can see in just a moment, he has this jaw clenching and posturing there. And in the second video, we see that he's able to stand up, maintain balance, and ambulate on his own. But you can see the wrist posturing, the movements there. And as he reaches out for the scarf, you can see there is no obvious ataxia there. And so GNA1 encephalopathy in and of itself is a really exciting topic with a broad phenotypic spectrum of epileptic encephalopathies and movement disorders, depending on the location of the mutation on the gene, GNA1 gene. And fun fact, our patient really had a mutation here with global developmental delay and movement disorders. But as a resident, the more important learning point for me really was how to approach a case such as this in an emergency situation. And so dystonic storming really is a complication of primary or secondary dystonia and is one of the rare movement disorders emergencies. characterized by frequent severe episodes of generalized dystonic spasms. About 1/3 of these events are unprovoked. Among the provoked events, the main triggers would include recent infections or recent medication adjustments. The main complications to watch out for would be bulbar weakness, compromising airway patency, progressive impairment of respiratory functions, metabolic derangements like rhabdo, or just sheer exhaustion from the persistent spasms. And then the figure to the right shows a typical course of dystonic storm. It'll start off with a prodrome where the dystonia is worse than baseline. And so our patient likely presented somewhere here. And once the true storming phase starts, it would last about 2 to 4 weeks with gradual recovery. Even with treatment, the mortality rates are really high. And so when encountering patients with worsening baseline dystonia, it's really critical to be vigilant so as to be able to initiate prompt interventions. And then I put this slide here. It really lists underlying scenarios where dystonic storming can happen. The main takeaway really being that de novo presentation of someone in storming is rare if they don't really have a prior history of dystonia. And then finally, coming to the management. Now, this is a really busy slide, but let me walk you through it. At the top, you see the different grades written here. And so in practice, really storming would occur at the end of a continuum of worsening dystonia. Along such a continuum, there's a paper by Lumsden and Stephen Frucht that really described a simplified dystonia severity action plan that can be used to assess patients at risk of progressing. And so clinical evaluation is going to be the starting point for defining any downstream therapeutic strategy. And so our patient really kind of fell between grades 3 and 4. And then once the patient is in storming, the initial stage is really going to be medical stabilization with supportive care. So addressing fluid resuscitation, antibiotics, addressing complications. And then an important measure at this stage is going to be to help the patient achieve control of the spasms and achieve some sleep without compromising respiration. And so depending on how aggressive of a treatment is required for refractory storming, IV propofol, IV benzos, et cetera, can also be used. And once the stabilization is achieved, we then look at the dystonia-specific medications, which would typically be a combination of cholinergics, GABAergics, and dopaminergic medication. And before I end, just for the residents, a quick word about the dopaminergic medications. So tetrabenazine is often used. It's a presynaptic dopamine blocker, a VMAT inhibitor. And so that has the most evidence. But in the acute phase, we often end up using postsynaptic dopamine blockers like the neuroleptics. And so these, while there's some evidence that it improves dystonia, the paradox is that it can actually cause acute dystonic reactions and tardive dystonia. And so routine use of postsynaptic dopamine blockers is generally discouraged. That is all I have for you.
Thank you, Mishy. So today's grand round speaker, we're very grateful, is Dr. Chantal Boisvert. I'm sorry I butchered that.
You did great.
Who's an associate professor of neurology and ophthalmology and chief of the division of neuro-ophthalmology at Duke. Usually at the beginning of the year, we have a lecture on neuro-ophthalmologic emergencies. And Chantal is great to have agreed to do this year on relatively short notice. She's a acclaimed teacher and a wonderful doctor and a great person. So I will throw it to you, Chantal, and you can take it away.
Thank you so much, Dr. O'Brien. Can you see my slides?
Yep.
Yeah. So I have to apologize. I just tested positive for COVID. So my my throat is not like happy right now. So I'll do my best. So yeah, it's really a pleasure to be here this morning. So basically, I will see this talk as an introduction to all the talks that I will be giving to the residents within the next few weeks. So we'll have talks on how to approach patients with vision loss, double vision, anisocoria and everything. So it's kind of like an introduction and looking at all the different things that I don't want you to miss. So the objectives is really to recognize the symptoms and the key findings on the exam that could prompt an emergent management for your patients. So we're going to talk about 3 different types of neuro-op emergencies. Really in clinic, I mean, we see other things in vision loss, double vision, and anisocoria, but this is mainly like the 3 categories where you can have emergencies, where you'll have to send the patients to the emergency room. The one I did not include is a ptosis. Oh, I'm sorry, my dogs are barking. So the ptosis, we'll talk a little bit about it with the other categories, but this is like really like the main 3 things I want to focus on. So vision loss. So the first step when you see a patient with vision loss, I'm so sorry about my dogs. So you have to ask the patient about which side is affected. Is it only one eye or is it both eyes? And is it something that is acute or it's something that is progressive over time? And are there any other associated symptoms with the vision loss? So why does it matter? So the side of the vision loss will tell you where the problem is. So if it is unilateral, so you have to think of something that is anterior to the chiasm. So basically that will be the optic nerve or the eye that will be affected. If it is bilateral, most of the time it will be something at the chiasm or behind the chiasm. Don't forget though that you can have a binocular eye problem that can affect the vision in both eyes. It will be really rare to have something that will affect the vision in both eyes at the same time from, like, for example, if you have like an ischemic event in one eye, it will be extremely unlikely to have an ischemic event in the other eye at the same time because it's not the same vasculature. We'll review some conditions that can actually affect the vision at the same time. In the time course, so when we think of something that is urgent or emergent, usually we will focus on the vision loss that is acute, so within seconds. So that's really telling us that there's ischemia. I mean, there's an ischemic event that is happening. Or sometimes even something that is subacute could be something urgent. For example, inflammation will give you something that is a subacute. So the patient will report that the vision started going away and it's progressively getting worse over a few days. And we'll come back to that a little later. If you have something that is more gradual or progressive, it's more rare to have something that is vision threatening or life threatening, but it can still be possible. So if you have a tumor, you can get a progressive vision loss and you can die from your tumor. But usually, I really want to focus on the acute onset of vision loss today. And looking at the associated symptoms will help you figure out what's wrong with the patient. So for example, if the patient reports having some periorbital pain or pain with eye movement or pain behind the eyeball with vision loss, you can think inflammation. So you can have an optic neuritis or orbital inflammation that can give that. If a patient reports pain and facial numbness, double vision and vision loss, you think more like something around the cavernous sinus that is moving forward from the cavernous sinus, because remember the optic nerve is not in the cavernous sinus, but it's just adjacent to it. So if you have a big lesion in the cavernous sinus, you can have vision loss if it's big enough to touch the optic nerve. And of course, if you have a headache, JAK claudication, and systemic symptoms, then giant cell arteritis becomes very, very likely, and we'll come back to that. So the rule of thumb, I mean, it's true not only for neuro-ophthalmology, it's like in everything in medicine, you always have to rule out the worst case scenario first. So always think of what is the worst thing that could be happening to the patient and rule that out before you rule out the things that are not life-threatening or vision-threatening, or at least that are treatable. So just make sure you always think the worst first. And I have some cases here. So the first case is an 82-year-old female that is complaining of a new onset of vision loss in her right eye. So she's reporting a black curtain that is covering the entire field of her vision. And she really reports that the curtain was really quick and it just went down. She has no other associated symptoms, and she's last known well about an hour and a half prior to presentation. So if we go back to the questions, the 3 questions, so the laterality of the vision loss is in the right eye. So you can think anterior to the chiasm. The vision loss is acute. So you can think ischemia, and there are no other associated symptoms. And on examination with her glasses, you find that she cannot read the chart, but she can see her hand moving. So she's hand motion. And in the left eye, she's 20/20. So the front part of the eye seems grossly normal to you. There's no hyperemia or nothing obvious. But when you check the pupils, you can see that the pupil in the right eye is not constricting as well as the left eye. So when you do the swinging flashing test, you see that the pupil is dilating, meaning that you have an efference issue in the right eye. And if we look inside the eye, that's what we see. So on the right side, it's actually the left eye. So you can see that the retina looks really, we see pink, it's not really pink, it's more like orange, but you can see the vasculature is normal and the color of the retina in the background is also normal. If you look in the right eye, which is on the left side of the screen, you see that the retina is really white. And white means ischemia. So that's the only way the retina can respond to ischemia, right? It will start swelling. And we talked about that last week for the residents that were there for the talk with Dr. Mishy Roy. So when you see this here, when you have whitening of the entire retina, and when the fovea looks red, that's what we call a cherry red spot. So it means that the blood flow is not coming into the eye. So that's a central retinal artery occlusion. And remember that a CRAO, central retinal artery occlusion, is basically the same thing as having a stroke. It's just that the stroke is in the eye instead of being in the brain. Remember the vasculature. So from the internal carotid artery, the first branch that you have is the ophthalmic artery. And the first branch of the ophthalmic artery is the retinal artery. So if you have an occlusion of the retinal artery, you're going to lose your vision in your eye. Same thing, by the way, if you have an occlusion of the ophthalmic artery, because the ophthalmic artery feeds also the eye. The difference between the two is, so the central retinal artery feeds the retina, and the ophthalmic artery feeds the entire eye. So it feeds the retina, but also the choroid underneath. So you lose the entire blood flow when you have an occlusion of the ophthalmic artery. So you won't see a cherry red spot. You'll see just white everywhere. And usually the vision loss is much, much worse when you have an ophthalmic artery occlusion. And you'll ask, why do we have an occlusion? Why is it almost always a central retinal artery occlusion that we get? Or why is it like an AMI occlusion? So either the upper retinal artery or the lower retinal artery. Why not seeing more branch occlusions? So sometimes we'll see just a tiny little branch that will be occluded if we have patients with chronic hypertension. So what happens in those cases is that the arteries in the eyes are very stiff and can push on, I mean, they're very stiff and they're like much thicker, so you can lose your blood flow. And also when you have that, you can also have like a vein occlusion from the compression from the artery, like in the periphery of the eye. But most of the time what we will see is central. So it's either an IMI field or the entire eye that is not getting the blood flow. And there's a reason for that. So if you look at the anatomy of the optic nerve, so here it's from like the side, right on the slide. So it's hard to see the lamina cribosa. But if you look at the picture here from the front, you can see all the little dots in the central part of the optic nerve. And that is the lamina cribosa. So that's a part of the optic nerve with holes in it, and the arteries are within those holes. So this is by far the main location where we get an occlusion, just because it's very, very tight in that area. And depending on where the occlusion is, we can have a central retinal artery occlusion or just one branch, because the branches start at the optic nerve as well. So the main causes of a central retinal artery occlusion are by far, I mean, the main cause is by far embolization. It's very similar to a stroke. So that's why we treat that very similarly to a brain stroke. But of course, other things can also give you an artery occlusion. So you can have atherosclerosis, giant cell arteritis. We'll come back to that in a second. And you can also have a reduced vascular perfusion or a vasospasm, for example, migraines. And as a rule of thumb, we say that vision loss over 90 minutes is unlikely to recover. So if you have a patient that is reporting vision loss for 24 hours and the vision got better, it's very unlikely that was an ischemic event, because after 90 minutes, you should start seeing some permanent damage. And as I mentioned before, so we treat that very similarly to a stroke. So we can do TPA if we're within the window. And we can also do hyperbaric oxygen, which is different from a stroke. And the reason for that is, think of the blood flow of the eye. So you have the retina, but underneath the retina, you have the choroid. So if you have a central retinal artery occlusion, your choroid is still bringing blood flow to the retina from underneath. So if you increase the oxygen level in the choroid, you're going to increase the oxygen level that the retina will get just by like perfusion. So the goal is to increase the saturation in oxygen while you're performing a clot bursting therapy. So that way the blood clot can dissolve. And in the meantime, the patient is getting the oxygen that is needed so the retina doesn't die. So usually at Duke, at least that's what we do for CRAO. So it's not yet a universal treatment, but our hope is that eventually we're going to publish our results. And we really hope that that will be the gold standard eventually. So if you look right now in the literature for a CRAO, they say to decrease the pressure quickly inside the eye. So they'll say like to massage the eye or do a little paracentesis, which is you go with a needle inside the eye and you release the pressure quickly. So you remove some fluid inside the eye. But the studies have shown that doing that is actually worse than the natural history. So we're really trying to more and more to treat a CRAO the same way as we treat a stroke. So a similar patient here so this patient is 73-year-old, it's a male, and it also complains of complete vision loss in the right eye. He woke up with no vision. Well, actually, I added the last known well 3 hours ago, but let's just say 8 hours ago. So he was sleeping and he woke up with vision loss. Prior to the vision loss, the patient reports a few episodes of transient vision loss in the same eye, in the right eye, over the past few days. This patient, however, complains of headache, jaw claudication, and weight loss. So here, just with these new symptoms here, you have to think of something else than just a regular CRAO. So let's go back to the three crucial questions. So the side of the vision loss is still the right eye, same thing, it's acute as well, but this time the patient does have associated symptoms that are very suggestive of giant cell arteritis. So remember, giant cell arteritis is a vasculitis that we see mostly in older patients, and it's inflammation of the medium to large vessels. The reason why we don't want to miss GCA is because the main complication that we get from that is bilateral vision loss. And when we say vision loss, it's not like a 20/40 vision, it's light perception vision, and sometimes even no light perception vision in both eyes. Very often the patient will lose vision in one eye and within hours or days will lose the vision in the other eye. So we actually want to catch that disease before we get to the vision loss. It's not because you don't have vision loss and means that the patient doesn't have giant cell arteritis. It can still be the case, but you just haven't reached the state of like the complication that you want to avoid yet. So if you suspect giant cell arteritis, start steroids right away. So if there's no vision loss, you can start just by mouth. Usually we say 1 milligram per kilo per day. If there is vision loss, usually we do admit those patients and give them a very high dose of steroids in the hope that the patient will recover some vision. It's very unlikely to recover vision with giant cell arteritis, but if we treat quickly enough, sometimes we can get a little bit of recovery. Don't be afraid to start steroids. If you think that it can be giant cell arteritis, do your inflammatory markers and start the patient on steroids, and then ask us to do a biopsy. And we have 2 weeks to do the biopsy, so we don't have to do it the same day. We have time. So if you suspect it and the ESR, CRP are elevated, just start the medication before the patient loses vision. And you'll say, why do they lose vision from giant cell arteritis? Well, by far, the main cause is an ischemic optic neuropathy. That's what we call the AAION. So it's an arteritic anterior ischemic optic neuropathy. Patients with that condition are very severely affected. About 21% of the patients will present with no light perception. I mean, it's no joke, right? No light perception, meaning not seeing anything. And the other eye can be affected within hours. So that's what we see the most, an AAION. And the picture that you have in the corner is actually an AAION. And you can see that the optic nerve is swollen, but it's also pale. A pale optic nerve with very severe vision loss is extremely suspicious for giant cell arteritis. It's not the only reason why patients can lose vision from giant cell arteritis. You can also get a CRAO, right? The case that we saw previously could also be from giant cell arteritis. So always ask the questions about like the symptoms of giant cell arteritis and check your markers as well. Don't forget that giant cell arteritis does not always give vision loss. It can also give some nerve palsies or double vision. And it's not very common, but it can still happen. So every time you see a patient with double vision, ask the questions about giant cell arteritis. So we talked a little bit about anterior ischemic optic neuropathy, the arteritic form. So we said that the vision loss is usually severe. We say like count finger or worse. The optic nerve is swollen and white. We can also see some retinal ischemia at the same time as the optic nerve ischemia, and I'll show you pictures in a second. If we do a fluorescein angiography, so that's when we inject fluorescein in the blood flow and look at the perfusion of the eye, we can see some abnormalities of the perfusion in the choroid, and I'll show you a picture of that as well. And sometimes you can even feel the artery underneath the skin. You can feel that it's like very, very hard, and there's no pulse to it, which makes the biopsy much easier, by the way, when you can feel it. So this is an AAION, so pale swollen optic nerve. And you can also have some retinal ischemia at the same time. So you still have an ischemic optic neuropathy, but you also have a branch artery occlusion. And you can see like the blood flow is kind of segmented within the artery right here. So if you have a combination of a retinal ischemia with an optic nerve ischemia, GCA is very, very, very high in your differential diagnosis. And the fluorescein angiography that I was talking about, so it's a yellow dye that we inject in the blood flow, and we look at what happens when the dye reaches the eye. So when it reaches the eye, the blood vessels turn white. So here we can see that the arteries are filled. The veins are starting to be filled because it comes later, right? But if you look underneath the retinal vasculature, that's the choroid that you see. And you see some areas where there's no white. So if there's no white, it means that you have a perfusion deficit in that eye. So perfusion deficit, patchy choroidal filling deficit in a patient with vision loss is also very highly suggestive of giant cell arteritis. So you'll say, how can we distinguish an arteritic ischemic optic neuropathy from a non-arteritic form? So the non-arteritic form is also an acute onset of vision loss. Usually it's altitudinal. Patients will wake up with vision loss either in the upper part of the vision or the lower part. It's never vertical. The way the vasculature is in the optic nerve and in the eye is all horizontal. So if you have a vertical split, you think brain. If you have an horizontal split, you think optic nerve or retina. So those patients will not have any symptoms of giant cell arteritis. And when we look at the optic nerve on the other side, so on the side that is affected, we'll see some swelling of the nerve. But on the other side, we'll see that the patient has what we call a disc at risk. So a disc at risk means a small optic nerve with no gap inside. So if you have a patient with glaucoma, for example, with glaucoma, you'll have a big cup in the center. So you have a big hole with a gap in the center. So that nerve has a lot of space. If you don't have a cup, it means that the nerve is filled with ganglion cell layers, right? It's like it's filled with fibers. those nerves are more susceptible to the ischemic event just because of the crowdedness of the nerve. So if you have one fiber that dies by lack of blood flow because of the crowdedness of the nerve, that fiber will start swelling and then will start pushing on the ones right next to it, and the ones right next to it will start dying. So it's really like a domino effect. And you'll say, why does it stop like in the midline at the horizontal line? So it's because of the way the optic nerve is actually made. So there's a gap in the center of the optic nerve horizontally. So if you have swelling of one fiber above the optic nerve, you need a pretty extensive swelling to go over that gap and affect the other part of the nerve. It's still possible, but I'll say most patients with that condition will have an altitudinal visual field defect. So this is not an emergency in the sense that we don't have any treatment for it. So we have to distinguish that from the arteritic form, but so it's really by looking at the color of the swelling of the nerve and looking at the other nerve and looking at the visual field and the symptoms and the inflammatory markers that we can distinguish the two. So case number 3. So we have a 78-year-old female that complains of an almost complete left-sided vision loss. And she's not sure if it's only in the left eye or in both eyes, but she feels it's only in the left eye. And she really reports that it's the vertical aspect, like the temporal aspect of the vision that is gone in the left eye. So remember, the optic nerve in the retina, the split is horizontal. So if you have vision loss that is vertical, that tells you brain. And that patient woke up with vision loss and has no other symptoms. And that is, so if we go back to the questions, so it's in the left eye, maybe both eyes, it's acute and there's no other symptoms. And that's really like your field of expertise here. So we have a visual field defect that is homonymous on the left side, and it's an acute onset. So by far, what is the first thing that comes to mind is a stroke. So it's a retrochiasmal lesion because it's bilateral and it's acute. So stroke is by far the first cause of that. And as you know, those patients need to be admitted for stroke workup. Case number 4, I think that's the last case of vision loss, and then we'll switch gears a little bit. So we have a 33-year-old female with progressive vision loss in both eyes. Started 2 days ago. She feels that it's worsening. Now she can barely see anymore. And she also reports some symptoms of bladder dysfunction and also numbness in her legs. So the laterality is in both eyes. The course here is subacute, right? So we don't really think ischemia when it's progressive over a few days, but she does also have some other symptoms that should tell you that it's not only visual, there is something else that is going on with that patient. And here with vision loss, both eyes, you do an MRI of the brain and you see that the chiasm is actually enhancing, which will explain the vision loss in both eyes. And you also do some imaging of the spine and you see that the patient has a transverse myelitis. So just remember that subacute vision loss can also be life-threatening. So here that's a patient that has NMO. So we'll talk about that way more in my talk on vision loss. But remember that NMO can be very severe and the patient can actually die from that condition. So you really want to be on the lookout for that condition. So if you have an optic neuritis that is bilateral, or if the vision loss is extremely severe in one eye, NMO always comes to mind. Or if the patient does not recover from the optic neuritis, it also makes NMO much more likely. Because remember, with MS, most patients will recover most of their vision within a few months. So if the patient does not recover or also has some symptoms of transverse myelitis, you'll have to rule out NMO because the treatment is much more aggressive than just the regular optic neuritis. So that was the vision loss. Now let's talk about double vision. So it's much shorter, the double vision section. So we have an 86-year-old female with a 2-day history of double vision. She also reports that she is starting to have a droopy eyelid on one side. It's getting worse, and also reports a little bit of pain behind the eyeball. Not too severe, but just a little bit of an ache there, and has no other symptoms. So you ask her about all the giant cell arteritis symptoms, and she has none. So that's the patient here. So you can see that the left eye, the pupil is a little smaller than the right eye. So the patient has a mydriasis in the right eye, so anisocoria, right? The pupils are not the same size. And if you shine a light in the pupil in the right eye, the pupil is not constricting. So it's a fixed and dilated pupil. You can also see that the eye is looking out and maybe looking down slightly as well. And here you see that someone is holding her lid up because that patient has a droopy lid on that side. So you have a combination of an exotropia, so a drifting of the eye, a ptosis, and a mydriasis. So that is very highly suspicious. So remember cranial nerve 3 palsy, what functions the cranial nerve 3 takes care of. So we'll take care of most of the extraocular muscles except the lateral rectus and the superior oblique. So the patient will have an up gaze deficit, down gaze deficit, and adduction deficit. We'll also have a droopy lid because the levator is also supplied by cranial nerve 3 and can have a dilated pupil, not necessarily, but can have, and that's the part that we absolutely have to look for when we see a patient with an acute onset of third nerve palsy. So when is it really an emergency when you have a third nerve palsy? Well, if the pupil is dilated, it is an emergency. So remember the anatomy of the cranial nerve 3. So you have the motor fibers that are like inside the nerve in the center, and you have the pupillary fibers that are outside the nerve. So if you have something pushing on the nerve, then the pupil will start dilating. And something that is pushing is not necessarily something that is super dangerous, but if it's something that is acute and progressively getting worse, it means that whatever is pushing is getting worse quickly. And the main thing that can do that is an aneurysm. So if you have a patient with like a tumor, like near like the cavernous sinus, you can also have a dilated pupil with a cranial nerve 3, but usually those lesions are more progressive. If it's really acute, you have to rule out an aneurysm. And the reason for that is, again, the anatomy. So you have cranial nerve 3 that is right here, and right next to cranial nerve 3, you have your PCOM. So if you have an aneurysm of the PCOM, it will start pushing on cranial nerve 3 and the pupil will be dilated. So in ophthalmology, what we use as guideline is if we feel that the pupil is partially affected, we will do the workup for an aneurysm. Be careful with the patients that present with a partial third nerve palsy. If you have just a partial limitation in up gaze, down gaze, and adduction with a mild ptosis and the pupil is not dilated yet, the patient can still progress. And when the patient progresses, the pupil can become affected. So we cannot only say that the cranial nerve 3 is pupillary sparing when you have a complete third nerve palsy and the pupil is normal. If you have a partial third nerve palsy, do the workup for an aneurysm because you don't know what will happen within the next few hours or few days. So if the pupil is partially affected, do some imaging to rule out an aneurysm. If it's dilated and fixed, what we call a blown pupil, I mean, this is something extremely urgent. I mean, you don't wait. You want to rule out an aneurysm right away. So that's like, in terms of double vision, that's really like the main condition that can kill your patient if you don't act quickly. Of course, you can still have life-threatening problems with other type of double vision, right? You can have a 6th nerve palsy from a tumor or from increased intracranial pressure, but usually you have more time to act. So this one, the cranial nerve 3 with a dilated pupil, is something that needs to be addressed right away. And the last thing I want to talk about is anisocoria, so a difference in the size of the pupil. So we have a 25-year-old female, and she is reporting a right-sided neck pain. And when you have a patient that comes, let's say, to the emergency with neck pain, you don't necessarily always look at the eyes, but you should probably do, because that can tell you what the problem is for that patient, and you can actually save the life of that patient. So here, this patient has right-sided neck pain, and look at her eyes. So it's pretty subtle. It's very easy to miss what's going on here. But if you compare the two sides, you'll see that The right pupil is just slightly smaller, not very obvious, right? Just slightly smaller. And there is a ptosis, minimal ptosis. And if you look at, I'm just going to go back here. So if you look at the lower lid, you can also see that the lower lid is sitting a little higher than the lower lid on the other side. So that's what we call a reverse ptosis. So if you have a ptosis of the lower lid, the lid will look higher. So if you look at the palpebral fissure, so the opening between the two lids, you'll see that the palpebral fissure is smaller on the right side than it is on the left side. So here, the combination of a ptosis with a miosis and neck pain is extremely, extremely suspicious for Horner syndrome. And when you have pain, be very, very careful, because that patient can die if you don't do something quickly. So remember the pathway, right? So it's a very long chain. So the sympathetic pathway starts in the hypothalamus, will go down, will go around the lung, and will go back up, go in the cavernous sinus, and go to the eye. So anything compressing that pathway can give you a Horner syndrome. And of course, not everything is an emergency, right? If it's a long-standing Horner syndrome, painless, you don't have to act quickly. But a patient like the one that we just discussed with neck pain and an acute onset of Horner, this is an emergency. And the reason for that is look at where the chain is. So if you have a neck pain, you can have a dissection of your carotid artery, and that will affect the sympathetic pathway, and then you'll get a Horner syndrome. So you'll say, how can I diagnose a Horner syndrome? Because sometimes it's not that obvious, right? We said that you'll have an anisocoria. The anisocoria should definitely be worse in the dark. And you should have a dilation lag. And the dilation lag is by far the main finding that will orient you towards a Horner syndrome. So when you turn the lights off, what happens is like the normal pupil will start dilating very quickly. And the Horner syndrome will eventually dilate, but it will take much longer. So when you turn the lights down, then the anisocoria will be pretty obvious. And the more that you wait, the more dilation of the Horner syndrome you're going to get, and then the anisocoria will become less obvious. So if you have that, it's very highly subjective of a Horner, way more than the ptosis or the miosis. So always look for the dilation lag. And remember that we don't necessarily have the ptosis, the reverse ptosis, and the anisocoria. So you can have just a partial Horner syndrome. So we talked about the workup. So we're looking at the anisocoria in the light and in the dark, and looking for the dilation lag. And I don't know if you do that in neurology, but in neuro-ophthalmology, we do some pharmacologic testing if we have a suspicion for Horner syndrome. And the main test that we use, I mean, in your books, I'm pretty sure that they talk about cocaine. We don't really use it as often. We use it in kids because they cannot use the other one that I'm going to be talking about in a second, because it crosses the blood-brain barrier. But in adults, we don't really use the cocaine test. So what cocaine does is that it releases the norepinephrine at the junction. So if you have a normal eye, the normal pupil will dilate, and the Horner syndrome will not dilate. So that will make the anisocoria more obvious. So what we do use in ophthalmology is apraclonidine. So apraclonidine is a medication for glaucoma. So we all have that in our clinic, like all the time. And it's very easy to use, and it's very safe in adults or in older kids. Usually we say like before 6 months of age, we cannot use that. After 6 months of age, we have to be extremely careful, and we have to do like the block the tear ducts to make sure there's no absorption. But in adults, it's extremely safe. There is no side effects from that. And it's an off-label application. So it's a medication that is an alpha adrenergic receptor agonist. So we have two types of alpha receptors. We have the alpha 1 and the alpha 2. The alpha 1, the apraclonidine has a very weak activity for the alpha 1. It's mostly the alpha 2 that will be stimulated. So in a normal pupil, what you will see is a mild constriction. And sometimes we use that medication to actually induce a constriction in patients that have severe light sensitivity. So a normal eye should constrict. Because with Horner's, you have denervation supersensitivity to the alpha 1 receptor, instead of getting the constriction, you're going to get the dilation of the pupil. So what you will see is a reversal of the corner, and even the pupils, not the pupils, the lid will also reverse. So the patient that we had before had a ptosis and a miosis in the right eye. If you do the apraclonidine test, you'll see that after half an hour, the corner will look like it's in the left eye. So you see a reversal. So it's very easy to see if the patient is responding to apraclonidine. So we said at the beginning of the talk to always think about the worst case scenario. So in that specific scenario here with that young patient with neck pain, a carotid dissection is by far the first thing that comes to mind. So you'll have to rule that out. So you have to do some imaging of the vasculature to rule this out. Of course, it's not the only thing that can give you a Horner. So the other like bad things that can give you a Horner are, of course, a cancer. So in kids, a neuroblastoma is by far the first one. In adults, it's mostly a thyroid cancer, because remember the location of your chain in relation to the thyroid, it's pretty close. So if you have a tumor that is pushing, you get that. Or a lung tumor, it will be a Penco's tumor, because the chain goes around the lung superiorly. And it can also be a stroke. So stroke can present with a Horner syndrome. But usually it's painless. So if you have a painful acute onset of Horner's, think carotid dissection, especially in a young patient. So that was it. So it's really an overview of like the main emergencies that we see in neuro-ophthalmology. So we will talk about that a lot. I mean, I think I'm giving like 4 or 5 talks within the next few weeks to their presidents, and we'll review again vision loss and anisocoria, double vision, and we'll really like go a little deeper to really try to figure out what's wrong with our patients. So I just wanted to remind you of the different conditions that can actually give you some permanent vision loss, or can actually kill your patient if you miss the condition. So that was it. So that was very brief, but I hope that you learn something. So if you have any questions, I'm all yours.
Thank you, Chantal. What are the names of your dogs?
Right now I have 3, because my daughter is home from college and our dog is here. So we have a willow, an aspen, and a maple.
Wow, I get the trend there.
I know, right?
Well, thank you very much. So anyone with a question, just raise your hand or put your name in the comments. So one thing I'm wondering, should our residents be walking around with eye drops, dilating drops in their pocket, or is that old school? What do you think?
Well, now with the new protocol that we have for the CRAO, I think, well, I don't expect the neurology to like do a very good fundus exam. I know that using a direct ophthalmoscope is very difficult, but using the eye drops for speed up the process when ophthalmology arrives, if you have like an acute onset of vision loss, actually, well, I mean, if you think it's it could be a CRAO, you don't have that much time to act, right? So you have like 4.5 hours, the same thing as a stroke. And sometimes the resident is actually at the VA or not on site. So we ask the neurology residents to actually dilate the pupil, so that way when the resident gets there, we can look right away in the eye and see if it could be a CRAO, and we can start like the TPA right away. So if the neurology residents do feel comfortable looking inside the eye, I mean, dilating the pupil is definitely much easier than not dilating, so you can try that. So I think the goal is like, now we're trying to, so you just bought like new camera fundus photos. So we're kind of trying to teach the residents to use the camera to actually look inside the eye instead of using the direct ophthalmoscope. I mean, I'm totally aware that the direct ophthalmoscope is not a very good instrument. We barely ever use it in ophthalmology, so I don't really expect the neurology resident to be comfortable with that. But if you want to dilate and do a fundus photos, that could actually be extremely helpful, because we can look remotely and tell you what's wrong with the patient, and we can treat the patient much faster as well.
So the message is, if you're in the emergency room and you're getting an opto consult, make sure the pupils react correctly and then put some drops in.
Especially if you think it's a CRIO. I mean, that's what we're trying to do now, just because it's really hard for the ophthalmology resident to come quickly to see those CRIO patients. So if it takes like half an hour, 45 minutes for them to just get to the emergency room, and then they have to wait until the pupil is dilated, you add another 30 minutes. So you kind of like, your window is like very limited. And often those patients do present also late after the vision loss. So I think that if the neurology resident could dilate the pupil, at least of the bad eye, so that way we can have a quick look and say, this is a CRIO, let's start TPA, let's send the patient to the hyperbaric oxygen. I think that will definitely speed up the process.
Marvin, did you want to make a comment?
Yeah, a couple of causes of acute bilateral vision loss are tip of the basilar syndrome, especially in older folks, where you include both posterior cerebral arteries and you get bilateral cortical blindness.
Right. Yeah, no, absolutely. You're right. I didn't talk much about stroke, but yes, yeah, you can definitely have a posterior circulation problem that could affect both sides.
Another cause is increased intracranial pressure, especially people with idiopathic increased intracranial pressure will go blind temporarily in both eyes, especially when they stand up.
That's correct. Like that. So they have what we call a transient vision loss, like a TVL. So this is with eye like movement, right? So like tying their shoes or like reaching something, like posture changes. So if you have transient vision losses like blackouts or grayouts, this is very suspicious for optic nerve edema. You're totally right.
Another cause of asymmetric pupils, especially in older folks, is that they've had prior cataract surgery.
Right, but this is definitely not an emergency.
That especially guarantees that they're going to have asymmetric eyelids, and so you wind up diagnosing a phony Horner syndrome.
Absolutely. Yeah, especially if they only had the surgery in one eye and the surgeon had to actually stretch the pupil to access the lens. Often that pupil will be a little larger than the eye that hasn't been touched. You are
so once they've had cataract surgery, all bets are off on the pupils, basically.
Yeah, I mean, this is definitely in the differential diagnosis of anisocoria, right? Just like a prior surgery.
Right.
All right, we have two more questions, but I'm going to record away. Blackouts are caused by raised intracranial pressure. Brian McGrory, and then Vinay.
Chantal, thanks so much for that really fantastic talk, particularly when you're not feeling well. I really, really appreciate it. I thought it was really interesting, you know, this kind of slightly less typical presentation of GCA as being an isolated, like, you know, third, fourth, or sixth cranial nerve palsy. Like when we're doing an acute evaluation on a person, like kind of what are some of the things that as neurologists we should look out for in the immediate setting in terms of distinguishing, say, like a microvascular third nerve palsy from one caused by GCA?
Yeah, so with an ischemic cranial nerve palsy, you can have a little bit of pain around the eye, right? But you should not have a temporal headache and jaw claudication and weight loss. So always ask the questions like about giant arteritis, look at all the different symptoms, and you should always look at the inflammatory markers just to be on the safe side.
All right,
thanks so much.
Vinay?
Yeah, thanks for the talk. I was wondering, I've seen some folks use this epiclonidine for mild ptosis for myasthenia.
Yeah.
And I'm told it's pretty expensive. Could you comment on that, please?
I've never used it for myasthenia, but I've used it for like mild ptosis, like from aging, for example, or for Horner syndrome. I don't know the cost right now. Eye drops are expensive. I cannot really tell you the difference between the cost of this one and the other glaucoma eye drops, but I think they're probably quite similar. So out of pocket is probably like over like $60, $80. They are expensive, but I do have quite a few patients that want to be on epiclonidine for either light sensitivity or mild ptosis because it definitely improves that. And it's totally off-label.
Is that the one for difficulty reading?
That's pilocarpine, so it's even stronger.
Does that help?
And the pilocarpine does not affect the lid. It's only like a constrictor of the pupil because it's not an alpha agonist.
All right, Chantal, perfectly on time. Beautiful talk. Unfortunately, by the time you do it next year, I'll have forgotten everything you said this year. So it's good to have it once a
Exactly.
All right, everyone, have a safe day. Thank you, and get well, Chantal. Thank you so
Thank you
much.
so much.